What if the medical answer to a declining libido, painful intimacy, and even urinary incontinence wasn't some daily pill you had to take?
Right. Or even an invasive surgery.
Yeah, exactly. What if it was just a small vial of your own blood?
I mean, it sounds completely like science fiction at first glance, but we are actually looking at a massive data-driven paradigm shift in female regenerative medicine right now.
It's incredible.
It really is. We are finally moving away from just, managing the symptoms of aging, and we're actually prompting the body to repair itself.
Welcome to today's deep dive. If you are listening to this, I know you are someone who loves to stay on the absolute cutting edge of health and science. You don't just want the surface level summary, right?
No, you want the actual mechanics.
Exactly. You want to know how the gears actually turn. So today, our mission is exploring this truly fascinating intersection of biology and female sexual wellness.
Specifically, we are diving into platelet-rich plasma, or PRP treatments.
Right, which in this particular context is commonly known as the O shot.
Yeah, and it's a topic that has generated just a massive amount of media attention over the last few years.
Oh, absolutely. It's everywhere.
But unfortunately, a lot of that mainstream coverage focuses purely on the sensational aspects, the celebrity endorsements or just the catchy name.
Yeah, they completely ignore the actual cellular biology that makes it work, which is exactly why our insights today are drawn from a highly rigorous, really diverse stack of sources.
We aren't looking at beauty blogs here.
Definitely not. We're looking at clinical studies from the Anatolian Journal of Obstetrics and Gynecology, a prospective study indexed in JAMA, and even detailed clinical protocols straight from the practices of medical professionals.
Right, so we are going to figure out exactly what PRP does inside the human body.
Where it's being applied, and why it is fundamentally changing the landscape of urogenital health.
But to do that effectively, we really have to start at the foundation. Before we can even talk about where this treatment is utilized, we first need to understand what PRP actually is.
And the biological mechanics behind it?
Exactly.
Okay, let's unpack this. Let's start with the raw material. I think I understand the basic concept of using my own blood.
Right, the autologous part.
Yeah, but blood is mostly just red liquid, right?
Mm-hmm.
So if you just take a syringe of my blood and inject it back into my tissue, I mean, that's essentially just giving me a bruise.
Yeah, pretty much.
So how do we actually isolate the regenerative material from that?
That is the crucial first step. So the core concept of platelet-rich plasma relies on it being an autologous treatment.
Meaning it comes from you.
Right. Autologous simply means the biological material comes from the same individual receiving it. Because it's your own material, there are no synthetic fillers.
No foreign chemicals.
Exactly, and therefore virtually zero risk of an allergic reaction. But you are completely right. Whole blood isn't the cure. It begins with a very small blood draw.
Like at a normal doctor's visit.
Yeah, exactly like you would experience at a routine physical. They will draw anywhere from 10 to 60 milliliters of whole blood.
Oh, so not very much at all.
No, it's a small amount. And the exact volume just depends on the specific proprietary collection system they use.
Like what kind of systems?
Well, the sources mention systems like Ridgen or TRPRP.
Okay, so we have a standard vial of blood. What is the mechanism that transforms that normal blood into a biologic treatment?
The magic happens in the centrifuge.
Ooh, the spinner.
Yes. This blood is immediately placed into a specialized machine that spins it at a precisely calibrated, extremely high velocity.
Think of it like a carnival ride that uses centrifugal force.
That's a perfect way to picture it. Because the components of our blood have different molecular weights and densities, this intense spinning forces the heavier red and white blood cells down to the bottom of the tube.
So what's left at the top?
What you're left with at the top is the lighter plasma. It's this golden, straw-colored liquid that is now incredibly concentrated with your body's platelets.
See, I've always thought of platelets just as the things that cause scabs when you get a paper cut.
Well, I mean, that is their primary job. Platelets are essentially circulating in your bloodstream in an inactive, dormant state.
Just waiting for something to happen.
Right, just waiting for an injury to occur. When you get that paper cut, they rush to the site and they clot.
But for PRP treatments, just having isolated platelets sitting in a syringe doesn't actually trigger the kind of tissue regeneration we want, right?
Exactly. They are still asleep. They have to be forcefully turned on.
How do you trick them into waking up if there isn't actually a bleeding wound?
The clinician actually adds a chemical catalyst to the isolated plasma right before the injection.
Oh, interesting. What kind of catalyst?
A very common one is a 10% calcium chloride solution. When this calcium chloride is introduced, it biochemically mimics the body's natural injury response.
So it fakes an injury.
Yes, it triggers something called the thrombin cascade.
Okay, think of it like a historic building where the repair crew is already asleep in the basement. They have all the tools, but they don't know the plaster upstairs is crumbling.
I love that analogy.
Right, so injecting that calcium chloride is like flooding the basement with a chemical alarm bell. It wakes the crew up, hands them the blueprints, and sends them directly into the walls to start laying new bricks.
What's fascinating here is how that repair crew actually operates on a cellular level once the alarm rings.
What do they actually do?
Well, when that thrombin cascade is triggered, the platelets undergo a process called degranulation.
Degranulation.
Yeah, they literally physically break open, they burst and release highly concentrated packets of bioactive proteins.
And those are known as growth factors, right? We hear that term thrown around in skincare commercials all the time.
Constantly, yeah.
But what are they actually doing inside the tissue?
They are essentially the chemical messengers that tell your cells to multiply and repair. We are talking about specific compounds like PDGF, VEGF, and TGF-beta.
Okay, let's take VEGF, for example.
Right, vascular endothelial growth factor. When VEGF is released into the tissue, it binds to the receptors of existing blood vessels.
And does what?
It literally tricks the body into growing brand new blood vessels branching off of the old ones. That process is called angiogenesis.
So it's building new highways for blood flow where the old ones might have collapsed or shrunk.
Precisely. And alongside that, these growth factors stimulate your fibroblasts.
Those are the cells responsible for structural integrity, right?
Yes. They stimulate them to synthesize brand new collagen and elastin. And also, as these growth factors are released, the liquid plasma begins to transform.
Transform how?
It turns into a gel-like substance called a platelet-rich fibrin matrix, or PRFM.
A matrix.
Yeah. This matrix acts like a sticky net, holding all those growth factors exactly in place at the injection site so they don't just wash away in the bloodstream.
Wow. So we aren't just plumping up tissue artificially with, like, a hyaluronic acid filler that dissolves in 6 months.
Yeah, no.
We are actually growing permanent new blood vessels and new structural proteins. That is incredible.
It really is a completely different approach.
So now that we understand we have this highly concentrated, incredibly powerful biologic repair crew loaded in a syringe, the next logical question is, where exactly do they send it to improve female sexual function?
Well, when we talk about the classic OSHOP protocol, the clinical discussion revolves around two primary anatomical targets.
Okay, what's the first one?
The first is the clitoral complex, so specifically the clitoral glands and the surrounding hood.
And the second?
The second primary target is a very specific area of the anterior vaginal wall.
Let's dig into the anatomy of pleasure for a moment. Why that specific area of the anterior wall?
The clinical data provides a very clear map for this. The findings published in the Anatolian Journal of Obstetrics and Gynecology from our source stack are particularly illuminating here.
What did they find?
They looked at exactly why the lower 1/3 of the anterior vaginal wall is the primary focus. They used immunohistochemical studies.
Which is a technique that uses antibodies to map out specific proteins and nerve fibers in human tissue, right?
Exactly.
So they literally created a map of where the most sensitive nerve endings are clustered.
Yes, and they found that this specific distal area, which is often colloquially associated with the G-spot, is neurologically unique.
Unique in what way?
It possesses a significantly higher density of nerves and microvessels compared to the rest of the vaginal canal.
Oh, wow.
Yeah, because of this incredibly dense neurovascular network, it is highly responsive to pressure and contact during intercourse. It's basically the neurological epicenter of the entire region.
Okay, but whoa, hold on. You are talking about taking a needle, even a tiny one, and putting it into literally the most nerve-dense, sensitive tissue on the entire human body.
I know, it sounds intense.
I am wincing just thinking about that. How is that not absolutely excruciating?
It's a completely natural reaction. I mean, the idea of an injection in such a sensitive area evokes immediate anxiety for pretty much everyone.
Yeah, I would think so.
But the medical protocols are rigorously designed to overcome this exact pain factor. Patient comfort has to be prioritized, otherwise no one would ever agree to the procedure.
What is the protocol then? Because a standard numbing spray doesn't sound like enough for that kind of nerve density.
No, it wouldn't be. Providers utilize specially compounded pharmaceutical-grade topical anesthetics. The gold standard is a BLT cream.
BLT, like the sandwich.
Sadly, no. That stands for benzocaine at 20 to 30%, lidocaine at 6 to 8%, and tetracaine at 4 to 6%.
Wow, why all three? Why not just one strong one?
Because they each have different absorption rates and durations, benzocaine hits fast but fades quickly,
Okay.
while tetracaine takes longer to kick in but lasts much longer. So by combining them, you get immediate and sustained numbness.
How long does it take to work?
This is applied directly to the mucosal tissues about 15 to 20 minutes beforehand. Mucosal tissue is incredibly porous, so it absorbs these agents much more efficiently than normal skin.
That makes sense.
And in many cases, this is also combined with a localized clitoral nerve block, or even just the application of ice packs right before the procedure to distract the local nerve endings.
And what about the needles themselves?
The actual injections are performed using ultrafine needles. We're talking 27 gauge or even 31 gauge needles.
Which are literally thinner than a human hair.
Exactly. But there's another crucial step here that the protocols outline, specifically for that anterior wall injection.
Well, what's that?
Because the PRFM matrix is quite thick once it activates, the practitioner doesn't just inject it and walk away.
Right, you wouldn't want a lump of it just sitting in one spot.
Exactly. So to ensure it doesn't just pool locally, they perform a specific post-injection manual massage technique.
How does that work?
It involves a firm, sweeping transvaginal massage across the lower one-third of the anterior wall. This manual pressure mechanically spreads that sticky fibrin matrix out, ensuring a uniform distribution of the growth factors across that entire highly vascular area we just talked about.
That is so precise. So between the powerful compound anesthetics, the microneedles, and the massage techniques, the clinical consensus is that the process is virtually painless.
Yes, and because it is your own blood, it requires zero downtime. Patients can literally drive themselves home or go right back to work immediately after.
Okay, well, that context completely changes the perception of the procedure. It goes from a medieval torture concept to a highly refined, comfortable clinical treatment.
It really does.
So, we've covered the biology and the delivery method. The name O-shot obviously implies that this treatment is entirely about orgasms. But looking at our source stack, the clinical data reveals a systemic impact on urogenital health that is so much broader.
Oh, it really is. The orgasm enhancement is just the tip of the iceberg here. The clinical benefits really cascade from one foundational change, which is the overall rejuvenation of vaginal health.
And this is particularly crucial post-menopause.
Very much so.
Let's talk about that, because menopause completely changes the chemical environment of the body.
Radically. When systemic estrogen levels naturally drop during perimenopause and menopause, the tissues inside the vagina begin to atrophy.
Because estrogen is what keeps that tissue thick, right?
Yes, estrogen keeps it thick, elastic, and heavily supplied with blood. Without it, the tissue loses its structural integrity. It becomes thin, dry, less elastic, and highly susceptible to chronic irritation and inflammation.
It's like a lush garden that suddenly gets cut off from its water supply.
Oh,
The soil dries out, it cracks, and becomes incredibly fragile.
that is a perfect analogy. So when you inject PRP into this atrophic tissue, the growth factors we discussed earlier go to work.
Right, the VEGF and all that.
Yes, they stimulate the fibroblasts to synthesize new collagen and use VEGF to build new blood vessels. It essentially replaces the old, worn-out, dry tissue with fresh, healthy, hydrated tissue.
Restoring the natural elasticity.
Exactly, and crucially, it restores the natural lubrication that was lost to those hormonal changes.
Wait, so if we are rebuilding that vascular network and restoring natural lubrication, wouldn't that inherently solve the friction and micro tears that cause painful sex in the first place?
It absolutely does, which is actually our next major clinical benefit, alleviating dyspareunia.
And for anyone unfamiliar, dyspareunia is just the clinical term for painful intercourse.
Right. If you're suffering from severe vaginal atrophy and dryness, intimacy isn't just unenjoyable, it physically hurts.
Yeah.
By utilizing PRP to fix the underlying physical degradation by restoring that thick, elastic, lubricated tissue, you completely remove the friction and the microtraumas that cause the pain.
And if sex doesn't hurt anymore, your desire to have it probably comes back, right?
Yeah, exactly.
Because so often, low libido is treated as this deeply complex, purely psychological issue. Women are told they're stressed or they need therapy or they just need to, relax.
No, absolutely. And while libido certainly has psychological components, if intimacy is physically uncomfortable or actively painful due to tissue atrophy, it is entirely logical that a person's desire will plummet.
Why would your brain desire something that causes physical pain?
It wouldn't. Addressing the physical discomforts of sex through regenerative medicine very often naturally resolves that secondary issue of low desire.
Right.
Once the pain is gone and healthy sensation returns, the libido frequently follows naturally.
Which brings us to the benefit that actually gives the shot its name-enhancing orgasms.
Yes. By regenerating the nerve health and increasing the vascularity to the clitoris and the anterior wall, the physical pathways for sexual response are repaired and optimized,
You are giving the nerves more blood flow.
which means they can transmit signals much more effectively. The data here is incredibly robust.
Yeah, let's talk about the data.
There was a prospective study indexed in JAMA that looked at women suffering from sexual dysfunction. Following PRP treatment, the orgasm subdomain scores of the participants jumped from an average of 2.11 all the way to 4.48.
Wow, that is a statistically massive leap in subjective experience and physical response.
It really is.
It's essentially doubling the measurable quality of sexual function. But here's where it gets really interesting. The next major benefit in the research has nothing to do with sex at all.
Right.
It's treating urinary incontinence. How does a shot designed for sexual wellness fix bladder leaks?
If we connect this to the bigger picture, the entire pelvic region is an interconnected system. The pelvic floor is like a muscular hammock supporting all your organs.
Okay.
The exact same drop in systemic estrogen that causes vaginal dryness also weakens the tissues lining the urinary tract. The muscles and fascia around the urethra lose their tone and their structural support.
So when you cough, laugh, or sneeze, the weakened structures just can't hold the pressure and you get a leak.
Exactly. It's called stress urinary incontinence. But by injecting PRP strategically near the urethral opening, those powerful growth factors act on the surrounding musculature and supportive connective tissues.
Strengthening them.
Yes, they strengthen the scaffolding of the urinary tract, offering a highly effective non-surgical relief from mild to moderate incontinence.
That makes total sense. It's the difference between putting a bucket under a leaky pipe versus actually repairing the pipe itself.
Exactly.
You are reinforcing the structural integrity of the wall around the urethra rather than just applying a superficial patch like a panty liner or, relying on a daily medication.
Right. It's treating the root cause.
It's genuinely fascinating. But our sources also show that the O-shot isn't the only way this regenerative science is being applied, is it?
No, not at all.
While the anterior wall and the clitoris are definitely the headline stars, practitioners are mapping out the entire pelvic region for specialized treatments.
They are. The scope of regenerative gynecology is expanding at just a rapid pace. The sources outline a total of 8 specific injection sites where PRP is currently being utilized to address highly localized issues.
What are some of those other areas? Because if the growth factors just heal whatever tissue they are placed in, the applications seem endless.
Well, beyond the 2 primary sites we discussed, providers are targeting the labia majora.
Okay.
This is sometimes requested for cosmetic plumping to restore lost volume, but functionally, it deeply hydrates the tissue and reduces chronic irritation. Then there is the vaginal introitus.
Which is the actual opening of the vagina, right?
Yes, it's frequently targeted for intense dryness or fissures.
And our sources also mentioned injecting into the perineum specifically to repair trauma and thick scar tissue resulting from childbirth episiotomies or tearing.
Yes, breaking down old scar tissue and replacing it with healthy, flexible tissue is a huge application for PRP. They are even targeting the cervix and the deep posterior vaginal wall, which are areas historically associated with deep pelvic pain during intercourse.
Wow.
It demonstrates the incredible versatility of autologous growth factors. Wherever there is cellular degradation or physical trauma in that region, the biological repair crew can be dispatched.
But to provide a truly well-rounded view of pelvic floor therapies, we can't just talk about needles, right?
No, we have to look at mechanical treatments too.
Exactly. Our source stack includes a fascinating clinical case report regarding a completely different non-injection approach to pelvic health, pelvic floor myofascial manipulation.
Yes, I'm glad you brought this up.
I saw this reference specifically for treating something called an atypical diabetic neurogenic bladder.
It's a vital part of the conversation. In cases like a neurogenic bladder, the primary issue isn't necessarily a lack of collagen or blood vessels. It is severe muscle contracture and nerve dysfunction.
So the muscles are basically stuck.
Exactly. The fascia, which is the tough saran wrap-like connective tissue surrounding your muscles, can bind up. When fascia gets tight, it literally strangles the local nerves and blood vessels.
Instead of injecting blood, how do they fix it?
Through incredibly targeted mechanics. Specialized physical therapists, perform manual myofascial manipulation.
Manual massage.
Right. They start externally manually massaging superficial muscle groups like the perineal central tendon. Then they actually enter the vagina to press on specific myofascial trigger points located deep within the pelvic bowl.
These are the muscles with the long names, right?
Yeah, muscles like the iliococcygeus, the ischiococcygeus, and the piriformis.
That sounds intensely targeted and honestly a bit intense for the patient.
It is, but it is incredibly effective for the right condition. This raises an important question about the future of personalized medicine in this space.
How so?
We are looking at two vastly different tools for pelvic health. PRP provides biochemical regeneration.
It creates new blood vessels and new collagen on a cellular level.
Right. Myofascial manipulation, on the other hand, provides mechanical relief. It physically reduces muscle tension, breaks up fascial adhesions, and mechanically restores blood supply by releasing trapped vessels.
So the success of the outcome depends entirely on the practitioner precisely matching the treatment to the patient's specific anatomical deficit.
Yes,
You
exactly.
can't massage away a fundamental lack of cellular collagen, and you can't use an injection to instantly release a severe mechanical muscle spasm.
Exactly. You need the right tool for the right deficit.
So what does this all mean? If we step back and look at the whole landscape we've covered today, the overarching theme is really unprecedented scientific precision.
It's a huge step forward.
Yeah, whether it's through the high-tech centrifugation of our own blood to isolate growth factors, or the incredibly precise anatomical knowledge required for deep myofascial massage, science is finally giving female pelvic health the nuanced, serious attention it has always deserved.
It's a profound shift in how we view women's health overall. For generations, women sitting in doctors' offices were explicitly told that these urogenital changes, the pain, the lack of sensation, the dryness, the incontinence, were simply a normal part of aging.
Right. They were framed as an inevitable burden that just had to be endured quietly.
Exactly. Just buy some lubricant and deal with it.
Yeah, which is just so dismissive.
It is. The clinical data and the advanced protocols we have explored today prove definitively that this narrative is entirely outdated. We no longer have to just manage the decline. We now have the biological and mechanical tools to actively restore function.
So, to summarize our deep dive for you today, PRP, commonly known in this field as the O-shot, is a highly versatile autologous treatment. By isolating and activating your body's own growth factors using a centrifuge and a chemical catalyst, it triggers true cellular regeneration.
Building new blood vessels, new collagen, and restoring nerve function.
Exactly. It offers significant, scientifically backed relief for a complex web of intimate health issues, ranging from painful sex and lack of sensation to the daily frustration of urinary incontinence. And it does so safely, without synthetic chemicals or major surgery.
By utilizing the body's own original materials, we are moving past temporary symptom management and fully entering the era of true tissue restoration.
Which brings us right back to that historic building we talked about at the beginning. We no longer have to just sit around, watch the plaster crack, and accept the structural decline as inevitable. We have the blueprint and the biological repair crew to fix it.
We finally have the right tools.
But before we wrap up, I want to leave you with a final thought to ponder. Something that pushes just beyond the edges of the research we covered today.
Oh, I love where this is going.
We have talked extensively today about using our own isolated blood platelets to trigger this amazing cellular regeneration. But regenerative medicine is currently accelerating at a breakneck pace across the globe.
It really is.
What happens when we eventually begin combining these precise PRP protocols with other emerging therapies? Imagine combining the localized O-shot with exosomes or highly targeted lab-grown stem cell therapies to achieve total non-surgical pelvic floor reconstruction.
The possibilities are endless.
How far can the body's own healing mechanisms take us when we finally give them the ultimate toolkit? That is a deep dive for you to explore on your own.